syndrome, a disease, right? There's all these like different different words that have been used to kind of define it. And of course, as you know, from a systemic perspective, you as a therapist, you are part of the, you're the observer, right? And so you're part of the system. So how you make sense of and conceptualize obesity as a phenomenon, as a term, will impact how you think about even clinical interaction, right? So it's critical for you all to explore your own personal beliefs, your own personal experiences, your thoughts, and how you think about this topic. And then how the problem is defined impacts your clinical intervention. Make sense? And so the first thing that I want you guys to always be thinking on, and this is whether you're talking about obesity or any other topic, is your epistemology, right? Who you are and how do you know what you know. And sometimes that means checking your biases at the door, right? Sometimes it also impacts, you know, well, this is my experience of the world, but it may be very different than my clients, right? So it's important for us to think about epistemology. So anything that I do when I work with clients, individuals, couples, and families, I always think about my epistemology. So, self of the therapist, this is me. The only one I think in here that knows this guy on the right is, oh, two of you. Aisha Williams and, oh, some of y'all. Oh, she said, I know you. I don't remember when we met, Dr. Brooks. How many years ago?
You were just getting ready to leave Virginia to take your job from me.
Oh, yeah, so I was over on this side. Okay, so this is me. This is me. It's all me, right? But this is my perspective and my experience. And for myself, I've dealt with issues around obesity and body image. You may not know that, or you might not think about that the first time that you meet me, which is, I find that to be fascinating. When I meet people, like, yeah, right, you're this one. Yeah, but I was 375 pounds, and I've dealt with all kinds of depression, all kinds of things. And I remember, I don't know if Mama Aisha, we call her Mama Aisha, first of all, and she was in my cohort. I remember, do you remember a time that you all were gonna go, was it to play laser tag? Do you remember that?
Uh-huh.
Okay, so there was a time when I was a student at Virginia Tech, and everyone was gonna go play laser tag. So we would try to do things as a cohort to you know, de-stress from the drama of being a doctoral student. Although I want you guys to consider that.
Yeah, like, be careful how you frame that.
Right. Let me frame that in a different way. But I remember we were all gonna go, and so they were like, yeah, you know, Darren, you gonna go with us? You gonna go with us? And I was like, no, I'm gonna stay out. You know, I was always kind of reserved, like, no, I'm not gonna go. But I remember during that time, the main reason why I didn't go was because I didn't think that the apparatus that you put on would fit me. And I don't even know if during that moment any of my cohort really knew that. But that was like a big thing for me. And so when they were like, oh, let's go, I'm like, oh no, you know, I got something to do, you know, I got other things to do. But in actuality, it was really because I felt like the apparatus wouldn't fit me, right? How many of you guys have done laser tag? So you know, well, depending on where you go, there's like an apparatus that you have to put in snaps in the front. And so at that moment, I was like, no, I can't go. This would be embarrassing for me. What would it be like to be among my colleagues and to try to put this on and it wouldn't fit, right? And then other times, we would travel. I don't know if you remember, we would travel, whether it's for MFP or other things. I would book a separate ticket because I don't want anyone to know that I have to have a seatbelt extender, right? So these are real things that impact people. And you don't always know because sometimes people carry around things and you would not know unless they told you, right? And so when I work with clients, it's important for me to share my experience because I want clients to understand that this is real, that it can impact individuals, couples, and families in a number of ways, okay? And so, yes, I've gone through my own weight loss experience. It is a journey. Someone used the term journey. But it's something that is very important to me as I think about the clients I work with. So, as we've kind of discussed, this topic titled obesity is really a complex phenomenon. It really has multiple factors. And I think that's part of why it's such a difficult issue to talk about, to address, because there's so many factors. There's biological components, right? Some of you talked about family history, genetic predispositions, right? Psychological aspects or the psychosocial aspects around the topic of obesity and how that might impact you as an individual and within couple and family relationships. Cultural, some of you talked about the cultural aspects. What does obesity mean within the context of your own culture and in your client's culture, right? A social aspect, there's some real social dynamics when it comes to obesity. I remember where do you sit in the room? Who sees you? For some people, you're invisible. For some people, you're not. You're completely visible. And it's an interesting, complex phenomenon because you can be visible and invisible simultaneously. Economics, we all know that obesity, as we think about the price of food, access to money to purchase food, right? Access to healthy foods. Spiritual, some people talk about obesity in the context of the spiritual aspect or dynamic. Family history, as I mentioned, race, class, right? Do you have the funds to be able to purchase certain things? Can you even go to treatment? Gender, as I mentioned, we talked about a little bit earlier. And age, so over time you can experience obesity or negative body image in various ways, right? And so a 6-year-old's experience might be different than a 16-year-old's experience, right? And then geographic locations, or where you live, and what's the dynamic or the environment around where you live. Here we go. Okay, here we go. So obesity, and I'm going to use a couple of different ways to define it, but considered a label for ranges above what is considered a healthy weight for a particular height. It's a general term, typically determined by the body mass index scale or BMI. So that's what some of you talked about, this aspect of BMI. Some of you hate it, some of you don't like it, some of you, that's fine. Though it does not directly measure body fat. And so that is one of the critiques, and I'll talk a little bit about some of the critiques to that. So some of the historical perspectives, obesity has been socially constructed as a disease, and therefore the focus has really been on weight reduction. And so I think that's why a lot of the focus and the discussion has been around, how do I increase your, exercise or intake of, appropriate foods. So then that becomes the discussion as opposed to your actual experience, right? And so it's been focused in the medical model, and the viewpoint is that obesity is sort of like an isolated incident, which we know that's not true, right? Some of us have thought that obesity is simplistically excess accumulation of stored fat, okay? There's a lack of consensus in how much excess fat is too much fat, right? And that's going to be the variation within various communities, right? And lack of consensus on how exactly to measure fat. So, of course, the general perspective is utilizing body mass index. It's kind of the most universal way to think about obesity. Of course, it's a height to weight ratio. How many of you in the room know your BMI? And how do you know? Did someone tell you, or did you calculate it yourself, or did the medical provider tell you? I'm just curious.
I looked it up. I looked it up.
You looked it up?
I'm curious. Medical doctor.
Medical doctor told you? Okay. Anyone else?
Looked it up.
But also, like, some of my weight loss apps, like Fitbit and stuff, also tell you your BMI, which weight is, and your height. So.
Okay. Okay. You said what, okay?
I said they always have a chart in the doctor's office. When the doctor's out, they just wait.
Let me see. I know. Okay, so one of the things that I encourage people to do, just as a frame of reference, is to know what their number is. Not that the number has to hold a certain kind of weight or power or anything like that, but I think it's just helpful to kind of know what people think about BMI. So of course, if you're a mathematician, you can calculate it by hand, but you can always just go to a website or an app or something to find out your BMI. So, according to the body mass index, a person is considered underweight if they have a BMI of less than 18.5. Normal weight, 18.5 to 24.9. Person is considered overweight if they have a BMI of 25 to 29.9. Obese if they have a BMI of 30 or higher. And then morbidly obese if they have a BMI of 40 or higher. The BMI categories are age independent and the same for both sexes. So obesity is also typically divided into subcategories like class 1, class 2, class 3 when it comes to obesity, of course. Class 3, BMI of 40 or higher, sometimes categorized as extreme or severe obesity. So just to give you kind of an idea, typically, generally, at least from a historical perspective, if you had a BMI of 35 or higher, you would, for most medical insurances, qualify for bariatric surgery. 35 or higher with a comorbidity like obstructive sleep apnea, diabetes, so on and so forth, right? I know because I wanted to have surgery at one point in time, but I couldn't afford it. So that's some class, some socioeconomic status that we can talk about. But even now, some medical insurances are starting to approve it as low as BMI of 30, which is really interesting. Yeah, specifically for the lap band procedure. So for children, overweight is defined as a BMI at or above the 85th percentile and below the 95th percentile for children and teens of the same age and sex. Obesity is defined as a BMI at or above the 95th percentile for children and teens of the same age and sex. So there's usually a CDC, there's a growth chart that you can use. Some hospitals have that available as well. So that's something to consider as well. So some of you talked already about this critique. A given BMI may not correspond to the same degrees of fatness in all cases. That's one thing that we know. So it could be 2, 3 different people in here, and we all have the same BMI on paper, but our actual level or degrees of fatness could vary. So it's like, well, that doesn't make sense, right? If this is supposed to really be the defining, aspect of how I think about myself in my medical classification, then there needs to be a better system. BMI may not be an adequate way of measuring risk for disease. Then there's also the health at every weight perspective. How many of you have heard of that or heard something around those lines? Okay, that you can be healthy at any weight. Doesn't matter if you have a BMI that is above the threshold for being overweight or obese. Then there's lots of discussion around muscle and how much that weighs, and so you can actually be very muscular and have a high BMI. So on paper it might say that you're obese, but in actuality, like you have 2% body fat or so on and so forth. And then cultural relevance. There's a lot of people who say, you know what, that's for a certain group of people, and I'm not a part of that group. How many of you have heard that? BMI is not for us. Anybody? Okay, who is it for?
White folks.
Okay, so there's that discussion, right, that BMI is like, it's completely irrelevant for me.
We don't want it though.
We don't want it though, I love it. So some people, once they calculate their BMI, they're like, wait a minute, is it realistic? It says that, like, is this real? Really? Am I really supposed to be this tall, this specific weight? What do you guys think? So what do you guys think about it? Do you buy into? Do you reject? Do you have a ambivalent kind of relationship with BMI? What's your relationship with BMI?
Well, I feel like if the purpose is to help with knowing if you're healthy or not, I don't think it's very useful as a measure. That's because I don't think it encompasses everything that goes into health and weight. And so I just don't think, I think it's an outdated measure. That's all.
Gotcha.
I read a research article at one point that talked about how when the BMI chart was created, the advertising industry actually paid millions of dollars to basically for them to create this BMI. So I struggled to find that at some point, but.
Interesting. Any other perspectives, what's your relationship like with BMI?
For me, I think about how any sort of blanket system doesn't work. It doesn't take into account any complexity or any sort of contextual factors, and any sort of measure that does that is ineffective. So like, regardless, like it doesn't take, it's black and white, and that doesn't work in the real world.
Because sometimes things are
For real people.
Yeah, absolutely.
I think socially we're very obsessed with numbers when it comes to weight. Like personally, I for myself, the numbers are a very big trigger for me. So I haven't weighed myself for the past 3 years. Like I threw the scale out the door pretty much since I started grad school. So BMI is just completely crap to me. I don't follow by it. I don't listen to it. I understand the importance of it, but it just perpetuates that culture of like numbers are important. You can size 0 or double 0, whatever it is. So
Sure.
it's just not for me.
Oh, yes.
You know, to be really realistic, I haven't lived with this. I can't say here, I can't say that, but I'm right in the middle because I know you're saying social posture, the numbers, it serves a purpose, but it's not for everybody, right? And so I kind of find that it's anxiety provoking a lot of times. You know, even when I thought I was healthy, I do weight. It induced a lot of anxiety. I need to know if I'm at that number, right? And then later on in life, when I had to accept my own body, I'm not there, but I'm going to go back to that, So I find that seems like more, I don't speak to myself, but more of the experience that anxious thoughts associated with it.
Sure. And one of the things that I think is important for you all as therapists is to keep in mind that BMI can be useful, but it also can be harmful. And so as you're working with individuals, couples, and families where this topic may come up, to kind of make sure that you stress that. Because there's a thin line, no pun intended, but there's a thin line between someone trying to make sure that they're at a healthy weight, and then now all of a sudden they've jumped over here, and now they're obsessed with that. Right? Now they're obsessed with that number. Got to be at that number. Got to be below that number. Oh, my BMI is, okay, I'm there. Great, fine. If not, what are you doing? At the gym. Right? So thinking about that and keeping in mind that BMI can be helpful, but it also can be stressed too much, and that can potentially create some problems for individuals. Okay. So just some general research. I know all of you probably know this, but of course, some of the medical research talks about obesity and its impact on individuals in terms of contributing to comorbidities or other health issues such as obstructive sleep apnea, hypertension, diabetes, various cancers, deaths, etc. Some of the research talks about that if you carry a lot of weight in the front, in the abdomen, that can have an increased rate or risk for diabetes and cardiovascular disease as well as colon cancer. Some things to think about. Traditional treatment, so a lot of this discussion, because it's been viewed from a medical model perspective, there's been focused on, increasing exercise, or, you need to go on this diet, right? Fad diet programs, the media talks about all these things. Every other week is a new diet program out, or some new celebrity endorsing some product. Over-the-counter medications and herbal supplements that some people utilize. Under the guise of I'm just being healthy, but you read it, it says, oh, this is supposed to induce weight loss or get rid of water weight or like whatever the case may be. Anybody know what I'm talking about? I'm just, okay. Supervised diet programs, so actually a program that may be supervised by a medical professional. Prescription medication, there's very small few of medication that specifically is prescribed to induce weight loss by a medical professional. One of the things I didn't put on here, but as we also know, when we think about obesity, some medication can contribute to weight gain, and that's a whole other discussion. Low-calorie diets or very low-calorie diets, I don't know if you guys have ever heard of that term, but that's also something that some people consider. And then therapeutic interventions as well. So why talk about it specifically within the context of African Americans? As we know from a health disparities framework or perspective, that although obesity impacts individuals, couples, and families across the spectrum, regardless of where you live, your race, culture, all these various aspects, there is a significant disparity as it relates to African Americans and Hispanic Latino populations when compared to white or Caucasian counterparts. And so specifically for youth, the prevalence of obesity has remained fairly stable at 17% and affects about 12.7 million children and adolescents. The prevalence of obesity was higher among Hispanics and non-Hispanic blacks than among non-Hispanic whites. The prevalence of obesity was lower in non-Hispanic Asian youth than in youth who were non-Hispanic white, non-Hispanic black, or Hispanic. Okay? Then once you jump on the adult side, more than 1/3, 36.5% of U.S. adults are classified as obese. Non-Hispanic blacks have the highest age-adjusted rates of obesity, followed by Hispanics, non-Hispanic whites, and non-Hispanic Asians. Okay? So it's important for us to think about this and talk about this because there are significant disparities. And depending on the context, where you work, the population that comes to your practice, you may see some of these issues come up in your session. So obesity among African American youth and families, what we know is that obesity does disproportionately impact the African American community. You really can't talk about obesity specifically for the African American community without thinking about it within the context of culture and race and tradition and legacy and experience, right? So we're talking about pre and post enslavement, right? Anybody know what I'm talking about?
Yes.
Okay. Cultural aspects of obesity. So what are those attitudes towards food, and what are their behaviors towards food, right? For example, in my family, everything is about food. Birthday, Christmas, just got an A on a test. For me, you got an A on a test, take my eat. Oh, let me get an A, because I want to go over Red Lobster. Right? Socioeconomic status, so food access, access to healthcare, right? Dominant notions of beauty, so some of you talked about body image, right? And weight preference. Oh, you know, she's all right. She got a little meat on her bones. That's okay. I like that. You said what?
But where?
But where? But where is that? That makes a difference.
It does.
Okay. Between you thick or not thick.
Right. And then they related back to the medical literature about like if you have high distribution in your abdominal area,
Sure.
not only does it lead to medical problems, but you're not as attractive because you don't have that shape.
That shape that everybody wants.
Everybody wants that shape.
Okay.
Yeah.
Okay. Yeah. Absolutely. Obesity and religion, the African American Church. So it's interesting. I've been looking at. I've done actually some research, but also been looking at obesity rates in the African American Church. And there's actually, they say it's a positive correlation that church attendance, that actually you have a higher prevalence of obesity. Which I'm like, wow, you know, well, we are eating after church. I'm looking after church, your house, my house next week, right? So I'm actually doing a study of where I'm interviewing pastoral leaders and asking them about, like, you know, what's your perspective of obesity and maybe your role in thinking about that within your church. So hopefully I'll find some interesting things in that study. Looking at family patterns, so transmission of food consumption practices and other patterns over, you know, generations, right? That children are socialized, right? You're taught how to eat everything on your plate, you know, can't get up from the table. Different dynamics within your family. So just really quick, I'm not going to do a whole history test and discussion, but the African diaspora is responsible for a huge transformation and translocation of millions of Africans during a 400-year period. During this journey, countless Africans, along with their foods and dietary customs, were carried throughout the Americas to become the primary candidates of an institution of slavery. Okay? Countless Africans, along with their foods and dietary customs. They were transferred, doesn't mean that they were maintained. Okay? So being part of the African diaspora has implications for the health of the transplanted Black or African populations. The overriding theme is that of disparity in disadvantage. The lack of control over lifestyle, diet, social circumstances may be entrenched factors that impact the obesity epidemic. So just imagine you have a certain practice around food, and all of a sudden that's controlled and dictated. This is an interesting perspective. So there's a higher prevalence of a disease conditions among persons of African descent. In general, a very distinct dietary trend exists in which the percentage of energy derived from fat and a marked increase in the presence of refined foods and meat products increases as one moves from West Africa to the Caribbean to the United States and the United Kingdom. This is just giving you some perspective, okay? Any of you heard of historical trauma theory?
Yeah.
Okay. So the premise of this theory is that populations historically subjected to long-term mass trauma, colonialism, slavery, war, genocide, exhibit a higher prevalence of disease even several generations after the original trauma occurred. Isn't that interesting? Links disease to both physical and psychological stress stemming from the social environment. In this framework, psychosocial stressors not only create susceptibility to disease, but act as a direct pathogenic mechanism affecting biological systems in the body. So, one of the things that you guys have mentioned was this idea about body image, right? So of course it's important for you to understand your perspective on body image, as well as your client's perspective on body image, right? So of course in some cultures, historically what we know is, and this was kind of discussed earlier, being heavy or overweight or having some nice, cushion or whatever you want to call it, is a sign of wealth, prosperity, right? Likewise, for some early European and African cultures, being skinny or underweight was a sign of poverty, sickness, and famine. Isn't that interesting, right? Even in current times, researchers have found that a number of groups across Africa prefer larger bodies when compared to smaller bodies, right? And very similar here in America. So dominant notions of beauty play a role regarding one's perceptions of what is and what is not healthy. And that ultimately may impact your client in their obesity status or not. So therapy, how might this issue, this topic, this phenomenon, this perspective really show up in your work? So it may show up in terms of childhood obesity as a family issue. So you may actually have, you may be referred to clients. So I've worked in pediatric obesity clinics. I've worked where medical doctors said, hey, this client is really overweight. They need to learn how to eat healthy, right? It could come up in terms of a weight loss program where people think about like how do you address the psychological aspects of obesity, right? Self-esteem issues or response to stress. There's lots of research about the correlation of stress and obesity. Comorbid with mental illness as part of weight loss surgery process, and then within couple and family relational dynamics. So it may show up in a clinical setting in terms of a hospital setting, intensive treatment in residential facility, during weight loss surgery process, as I mentioned before, an outpatient in terms of your private practice, a collaborative health clinic, right? I'm not sure how many of you have had access to that in your master's program doing internships. I know in my former institution we had a specific internship site that was a pediatric collaborative health kind of clinic. And then home-based intervention, and I'm going to talk a little bit about that in a little bit. So, inpatient, outpatient, you might work with hospitalized patients to identify issues around eating and negative compensatory behaviors. So those compensatory behaviors we're talking about, binging, purging, those types of things, right? Develop treatment goals with an emphasis on rehabilitation. Focus on treatment and appropriate discharge planning. Obviously, right? You need to get them out, get some new people in. Work with clients to address family and relational issues related to obesity and mental health. Okay. There we go. So weight loss surgery. You might work with individuals prior to surgery to prepare patients for significant change, and you might work with them after surgery. And I have this picture. Have any of you seen this actress? Okay. She just wrote a book called This Is Just My Face. Try Not to Stare. I'm like halfway through it. It's very interesting, very fascinating. But she talks about her experience, essentially in very many different ways. but she talks about her weight loss and her issues around weight. Okay? So the case study that I showed you was her. And that was her story. And some of the dynamics of bulimia, that comes directly from her. Those quotes were her quotes. Okay? And so it's interesting when you think about it in a real perspective, some of the things that people might be dealing with, and you don't even know it because you're a Hollywood star. Right? Supposedly you're a Hollywood star and you don't have any issues or problems. And I think another just little piece I think is really interesting, I don't know if you've heard about some of the things that people talk about her like, oh my gosh, it's just so horrible, the things that people say. But I've noticed that there's a difference between how people talk about her than how they talk about, how many of you watch This Is Us? Seen it?
Yes.
It's a different conversation. It's a different, I don't know if you've paid it, it's a different conversation. I'm sure the main character has had negative feedback as well, but it's a different conversation when we think about it. So even context is important. Group therapy, you may be doing any of you do group therapy with youth? Any of you? Okay. So you might show up in group therapy, working with youth to provide a safe space to discuss issues, concerns, and experiences. You might talk about obesity, body image, eating disorders, coping skills, body acceptance, anger, self-esteem, depression. Bulimia, right? Any of you worked with a client that experienced bulimia? Any of you know of someone that has experienced bulimia? Okay. So it might come up in the context of bulimia, whether it's the purging type, vomiting, misusing laxatives, diuretics, enemas, non-purging type, fasting, and excessive exercise. It may be within the context of antidepressants that might be prescribed. Just have like a lag. There we go. Okay. Binge eating, you know, with the emergence of DSM-5, binge eating has been its own separate classification, which is interesting, because initially before it was not. But occurs when a person loses control over eating. So I think someone earlier talked about control, right, and how that might be part of this dynamic. And cyclical, emotions like guilt, shame, distress about binging may lead to more binging. And that's this cycle that might occur for some individuals. Individuals are typically overweight or obese, but not necessarily. You can be engaged in binge eating and be underweight, have a normal BMI, so don't believe the hype. Okay? SSRIs, anticonvulsants, anti-obesity medications might be prescribed. Antidepressants may be prescribed. It might be part of this, part of treatment. So psychosocial aspects of obesity. So while obesity is like it's not a separate kind of diagnosis, right, in the DSM, but it is talked about within some of the medical issues, but then also within the context of eating disorders, depression, negative body image and self-concept, social stigma. Anybody know anything about social stigma or weight-based discrimination? Right? So there's lots of research that talks about this person goes and interviews for a job. They're overweight or obese, right? May have the qualifications. And then another person that might interview have the same equal amount or less, and it might impact the hiring process. Think about it. What do you think about when you see an obese person and what that means? So there's been some research that talks about weight-based discrimination and stigmatization. Bullying, some of you talked about bullying in the small groups, right? Especially during the adolescent phase. Elementary school, middle school, high school, right? People like to be mean and angry and nasty. And of course on social media, right? People can be cruel on social media. Social physique anxiety, so a person just may have this issue with being around other people. I don't want to be around people. I don't want to go to the swim pool in the summer. I kind of isolate myself, right? So these are some of the psychosocial aspects of obesity that don't always get talked about, but it's up to you to bring these topics up in sessions. body image, as we talked about, in terms of dominant notions of beauty, gender socialization, how you're socialized, right? So I remember I was told, yeah, play football. You should be on the football team. I was like, no, I want to play basketball. No, you're too big to play basketball. You need to play football. And it's interesting because I don't like football. I'm not a football fan. I like basketball. So being a young person and being told, no, you need to play football, and I'm like, I don't want whatever you did. Like, I wasn't about that life. I just wanted to like dribble and like shoot, you know. And I swear, I mean, I have a jump shot, like that'll save lives. But no one would know it if you don't give that person an opportunity, right? So thinking about body image and also culture and gender socialization. So you might work with clients in terms of motivation for change. So thinking about, you all know the trans theoretical model, right? You guys have learned it in your training at some point, right? No? Right? Yes?
Yes.
Give it to me, let me know. Okay, so you know about the various stages of change, so you might work with clients to kind of assess where they are in that process, if they are interested in making a change, and specifically what that change is. It doesn't have to be weight loss, but it could be other dynamics as well. So therapeutic perspectives. Okay. So you all know about common factors. I'm assuming you know this stuff because you guys graduated from wonderful, amazing MFP programs, right? Right?
Yes.
So I'm gonna need y'all to get your life together, right? So you guys know about the common factors, right? Approach to therapy suggests that effective psychotherapy models have shared commonalities, correct?
Yes.
Okay. It might appear on the license exam, so go back and do a little tutorial. Go back and do a tutorial. 4 factors are shared across psychotherapy approaches: client and extra therapeutic factors, relationship factors, model technique factors, and placebo factors like hope and expectancy factors, okay? Relationship factors. The client-therapist relationship contributes to 30% of change in therapy. Relationship factors comprise of clients viewing the therapist as caring,